This talk, we're going to go over normal pregnancy. There's a ton of different definitions that we need to cover, and then I want to wrap up with going over some of the notes because there's a lot of documentation involved with having a kid. So that's what we're going to do. We're going to start with our normal disclaimer. This is just health information for education, for thinking about, certainly not to be used to manage patients, and if you have a problem, see a medical professional. Take care of yourself. All right, so starting out with the stages of labor. So the definition of labor is regular uterine contractions that cause cervical change. This is classically divided up into 3 different stages. So there's stage 1. It has 2 parts: a latent phase from when contractions start up to 4 centimeters dilation, and then an active phase that's greater than 4 centimeters up until 10 centimeters. The slowing off in dilation that happens at the end of active phase, or can happen at the end of active phase, is sometimes called transition phase. But that's not one of the 2 classic parts of stage 1. So stage 1, latent, 0 to 4, active, greater than 4. Stage 2, so now that's delivery of the baby. So 10 centimeters fully dilated up until delivery. This can be divided up into a passive part, so that you're fully dilated, but you're not actively pushing, and then an active part. That's the active pushing. Stage 3, delivery of the baby to delivery of the placenta. All right, so we need to go into these a little bit more to understand what's normal, because if someone's not progressing through these stages normally, then they could either have a prolonged labor or an arrested labor. In either case, that could change management. Maybe a prolonged labor might be augmented. An arrested labor may have to have a C-section. All right, so we're going to go through the limits of normal here. So in stage 1, 0 to 4 centimeters, the latent part of stage 1, 20 hours primiparous, 14 hours multiparous. Those are maximums. Okay, stage 1, the active part, 1 centimeter per hour. That's the rate you should be dilating for primiparous. 1.2 for multiparous. Stage 2 is delivering the baby. That can take up to 2 hours once fully dilated in primiparous, and you add an hour for epidural, or that's just a general term for regional anesthetics, analgesics. All right, and for stage 2 in a multiparous, 1 hour is the without epidural, and 2 hours is with analgesia. Then stage 3, delivering the placenta, 30 minutes. Okay, and so all these are the maximum. Once you're about slower than this, then you're into the prolonged stages. But this it's different than normal. Okay, so normal latent phase, an average, a mean, might be more like 10 hours for primiparous or 6 hours for multiparous. The normal rate of dilation they'd expect is around 2 to 3. Okay. And so the way they come up with what these cutoffs were with the thing called a Friedman curve. So they did a study, I think it was in the 50s or 60s, so quite a long time ago. They looked at thousands and thousands of people going through labor, and they found that there was this stereotyped pattern that they would go through. So they'd start out here in the latent phase, not really very much cervical change, contractions going on. That would go on for a long time. Then at around 4 centimeters, the rate of change would really pick up, increase, and it would kind of maybe level off a little bit at the end. And that's how they came up with these different stages. That's how they came up with these cutoff lines. These studies have been repeated more recently. That's here I put the Zhang curve, and that shows that there's a more recent study with contemporary women has shown that the cutoff might be a little bit less dramatic than shown here at this 4 centimeters. Might be more of like a gentle slope, and the range of normal might be a little bit wider than was previously thought. All right, and so if there's a problem with going through these stages of labor, then that's when you consider the 3 Ps. 3 Ps of labor, right? So the power, uterine contractions, the passenger, that's the fetus is a macrosomnia, maybe it's really big. Then the pelvis, is there cephalopelvic disproportion? Is the pelvis too small to allow delivery? Okay. So the cervix, let's examine the cervix. There's a number of things here we just want to go over quickly just to define them, because this is a sort of unique area of that's not part of your normal exam, right? So we have the cervix here. We'll just draw a picture. So the inside we have the uterus, and then the outside we have the vaginal canal. Okay, and so you have the dilation that's measured at the internal os. So how much space is there between there? Dilation. Effacement and cervical length, that's 2 measures of the same principle. So effacement is thinning out, which, as you can imagine, the fetal head's up here pushing down. The cervix is thinning out, so you can measure effacement. Maybe it's 50% effaced. Maybe it's almost all effaced. It's very thin, so like 80% effaced. Right? And then you can also measure the cervical length. So you could say that 1 centimeters, 2 centimeters, 3 centimeters. Ripening or softening, just what it says. Does it feel hard? Does it feel soft? And then position, that's the position of the cervix in relation to like the angle of the uterus, and that's used for the Bishop score, and that's kind of the only time I've really seen that come up. happen. So the way you report this is you have, so dilation, let's say 5 centimeters, effacement or cervical length, so we could say, let's say 40% effaced. And the third thing you report is station. It could be 0. All right, and so station we haven't really talked about, so we're going to talk about it in the next slide. So the fetal station is the relationship where the fetal head is to the ischial spine. So you know you have ischial spines coming down here. And you have this fetal head that's going to pass from the uterus down. It's going to touch the cervix, go out the vaginal vault, and then be delivered. And so you can measure how far away the fetal head is from the ischial spines intravaginally as part of your exam. And then you get that as a number as a fetal station. So sort of like saying how high up is the baby. So if you're at the level of the ischial spines is 0. If you're before, then you're negative. And if you're past, then you're positive. Okay. And this is important in a number of different contexts. One is the Bishop score, so calculating if an induction will be successful or if you should do cervical ripening and things like that. And it's also important for operative delivery. So if you're using a forceps or a vacuum, you want to know the fetal station, because that can be a high fetal station or a high position. It can be a contraindication for doing those things. So the presentation, we're going to contrast presentation and position here. So presentation is what part of the fetus is going to be touching you, what's coming out first. That's what it's asking. And so you can figure out the lie using Leopold's maneuvers. That's just palpating around, feeling the uterus, feeling the top, the bottom, the sides from the abdomen, and seeing is it transverse, like this, or is it longitudinal, which would be like this. And then so let's say you know that it's longitudinal. You want to find out, is this breech or cephalic? So what's going to be coming out? Cephalic means the head, which would be the more normal. That's what you want. And breech would be the butts coming out first. And so the breech or cephalic can be further subdivided. So let's say you have a cephalic presentation like this. So the head's coming out. Is it the vertex of the head? So if you're going to be able to feel the head, will you be feeling the anterior, posterior fontanelles, things like that? Or are you going to be feeling the face, the brow? Is there going to be an arm sticking out, a compound presentation? And then same with breech. Is it frank, complete? Is there a foot sticking out? Okay, so that's how you subdivide up breech and cephalic presentations. Position is generally speaking, position will be a further classification or division of a vertex presentation. You have a vertex presentation, so you have the head coming out, and you're feeling that it's the skull here with the fontanelles. That's the vertex presentation. And now you want to know the fetal position. The way to figure that out is you look at how these fontanelles are oriented, or how the heads are oriented with respect to the maternal pelvis. All right, so you feel the fontanelles, and you can tell the difference between anterior and posterior. So if you remember, the anterior fontanelle is the more triangular, larger one. You have the parietal bones and the frontal bones coming together and form this larger triangular fontanelle, or diamond-shaped, diamond-shaped fontanelle. It's larger and it's diamond-shaped, just as the picture showed. Anterior fontanelle. Then posterior, you have the smaller triangular one. All right, and so the way you record this is so you feel the fontanelle, and let's say you have this one. You have the occipital part, right? Anterior, so you'd write that as OA. This is the maternal pelvis. This is the pubic symphysis, the anterior part. You're feeling the posterior fontanelle. This is the occipital bone, the occipital part of the head. So the occiput is anterior, and that'd be a normal type of position. Then you could, or alternatively, you could feel here. You could feel the anterior fontanelle here, close to the anterior part of the maternal pelvis. Then you'd say the occiput is posterior, and then if it's deviated off to the side, you could say the occiput is transverse, or the occiput is right or left, depending on how it's angled. All right, so I think you can see how you make that chart. It's based on where the occipital part is, which you figure out based on feeling where the posterior fontanelle is in relationship to the maternal pelvis. And this can be important because if you have, for example, OP, occiput posterior, that's not the normal position. Right? Normally the face isn't facing the pubic symphysis and the maternal pelvis, so that can be a sign you might have a prolonged labor. Or if the occiput's transverse, that can also be a sign of that. All right, so here's the Bishop score. So the Bishop score is helping to answer this question of will an induction be successful and should you do it? And what it uses is all the different things we've learned about already in the cervical exam. So dilation, how much dilated is at the level of the internal os? The effacement and the length, is it thinning out? The cervix thinning out? The station, are we high up in relation to the ischial spines? Are we close to them? Are we past them? Is it softened? Is and is the cervix posterior, intermediate, or anterior. And here's some modifiers that you use down here to modify the point system. So you just fill this chart out based with either what you've discovered or what you've seen recorded, and you just come up with some points. Then you add points for prior vaginal deliveries for preeclampsia. You subtract points from being post-dates, not having any vaginal deliveries, or having PPROM, preterm, premature rupture of membranes. Then you get a number. And so what you should remember about the numbers is 5. All right, so if you're less than 5, it means you don't have a good chance, less than a 50% chance that induction will be successful, and you should probably do cervical ripening with a prostaglandin. If you're greater than 5, then you have a better chance of induction being successful and can consider it. And if you're 8 or 9, then you have a very high chance that you'll have a vaginal delivery. All right. So I think that covers that. We'll go on to the cardinal movements. So these are stereotype movements that the fetus makes on its way out, and only a few of them I think are important to know about or help you conceptually. So one is engagement. So that's when is the fetal head coming in contact with the cervix, pushing its way into the pelvis. That's important pathophys-wise, because you remember that when you have the fetal head pushing, then you have prostaglandin release, and it starts the process of loosening up the collagen, breaking disulfide bonds, and cervical thinning and effacement. Right, and that's why prostaglandins you can give them to cause cervical ripening, or they can be caused by released by the head engaging into the pelvis, or you can be mechanically dilated, have a balloon dilation pushing on the cervix, causing release of these prostaglandins in this process. That's like a little pathophys tie-in. And then the other thing I think that's important to think about is when you have delivery, you have these bony structures here, which really can create some constraints to what the fetus can do. So you have a pubic symphysis, then you have like a sacrum like this, and then you have the fetus being delivered. So we'll just draw it here like this. That's supposed to be a nose and a mouth. All right, and so the movements that it has to make to get through here, or has to flex, as you can imagine, sort of getting underneath the pubic symphysis, that's flexing, and then on its way out, it extends. Right, and that'll come up knowing that that's sort of this flexion, and then there's this extension. Getting out of the bony canal is important when you think about how you're helping with the controlled deliveries, the steps of controlled delivery. All right, so now we're going to talk about that. So when you see crowning, that's when you see the head actually starting to come out a little bit. Then you know, okay, we're getting close, and so you have to get glove, gown, eye protection, the little cart that has the clamps, and the tubes for collecting umbilical cord blood and all that stuff set up. And then your goal when you're delivering the fetus is to have what's called a controlled delivery. So you're going to use your 2 hands, use bottom hand to support the perineum, the top hand to control the fetal head. So the fetus is coming out, it wants to extend, right? We said it has to pop out from underneath, from out of the pubic symphysis. So you're going to be seeing, assuming you're in occiput anterior, which is a normal position to come out in, you're seeing the back of the head on your hand, and it's going to want to extend. You're going to apply gentle flexion to that, okay? So you don't want it to extend very rapidly and forcefully, because that can increase the chance of lacerations and tears. Okay, so that's the first thing, and then you get the head delivered with applying some gentle flexion to help prevent lacerations and tears. Then you suction the upper airway, and you look to see if there's a nuchal cord. That means a cord wrapped around the neck. If there is, you reduce that cord, meaning you move it out of the way. Then you apply a little bit of downward pressure to deliver the shoulder, and then some upward pressure to deliver the posterior shoulder. So downward to deliver the anterior shoulder, upward to the posterior shoulder. Then it's gentle traction, and the rest of the body should come out. You cut the cord, you clamp, the baby goes to the pediatricians. All right, so some other just brief issues that we'll talk about that come up with vaginal delivery. So one, episiotomy. So the procedure that's used is a midline or median episiotomy. It's a skin from the posterior fourchette, or where the labia minora meet. So you make a little incision from there down toward the perineal body. And it's not done prophylactically. I think that was done at some point in the past. These were done very commonly, sometimes before there was really an indication for them. But now, because if you do an episiotomy, you're more likely to have a 3rd or a 4th degree laceration or perineal tear. They're not done as frequently, and the indication for them are shoulder dystocia, one that's happened or impending, or if there's some other reason that you really need to hasten delivery. All right, and then the other thing to mention is an operative vaginal delivery, and so this comes up when you're stuck in stage 2. So we know we're at stage 2, so we've gone through stage 1, so we're fully dilated, but there hasn't been delivery yet. So there's some just general indications that are for both forceps and vacuum extractor, and those are the two types of an operated delivery. So the station can't be too high. So it should definitely be greater than 0. So at the ischial spines or greater. You should not try this when the station's above the ischial spines. And also you need to have the fully dilated cervix to be in stage 2 and have the membranes have already ruptured. So these are the indications for both. And usually they're done when the station is lower than 0. So it's like +2 is the normal station. All right, so the forceps are metal, like spoon-looking things that go around the head and help assist with delivery. And the vacuum extractor is the pump-up suction device that goes on the fetal head and helps pull down during a contraction. So the complications of these, as you can imagine, laceration, bruising to the fetus, the mother, facial nerve palsy, and some things that are more unique to the vacuum extractor, scalp laceration, cephalohematoma, and subgaleal hemorrhage or hematoma. And so the subgaleal just deserves just a moment of talk. We'll probably talk about it more at some other point here as well. But so when you have on the skull, you have bones, right? You have sutures between bones. On top of bones, you have the periosteum surrounding a bone. Periosteum. Then above that, there's this aponeurosis. In subgaleal hemorrhages, you have hemorrhage in between this aponeurosis and the periosteum. So it's deep to the aponeurosis and superficial to the periosteum, and it does not respect these suture lines. The bleeding can just occur all over underneath this aponeurosis, which provides a lot of space for bleeding. You can have hemorrhage, you can have shock, hemorrhagic shock. I mean, significant volumes of blood can go into the space between this aponeurosis and the periosteum, and that's as opposed to a cephalohematoma, which is blood underneath this periosteum, between the periosteum and the bone. All right, so if you have blood in there, it cannot cross between the sutures, so it will respect the sutures. And anytime you have this bleeding with little kids, usually it's not picked up right at the birth, like maybe 10, 12 hours later, and you have to think about high bilirubin as this blood gets resorbed. And also, if you do see some subgaleal, you have to think about, is there an underlying problem too? You have to rule out underlying fracture, underlying intracranial bleed with that, because there's a high association between the two. All right, and so after you've done that, you've delivered the baby, you can maybe had to deal with episiotomy or operative vaginal delivery, then you deliver the placenta. And so for the deliver the placenta, you want to wait for there to be signs that the placenta is separated, because you don't want to be pulling on the placenta before it's separated. That's sort of a natural thing that happens, and after it, you can apply some gentle traction and should be able to easily deliver it. So these signs of separation are a gush of blood, cord lengthening, and fundal rebound. And you deliver the placenta, you apply some pressure, suprapubic pressure as well. So let's just here, put the pubic symphysis here. So we'll put the uterus here. I'll put the placenta back here. And here's the cord. All right, so delivering a placenta, what do? You put a little bit of suprapubic pressure here on the uterus, and you apply some gentle traction to the cord after you've seen the signs of placental separation, gush of blood, cord lengthening, and fundal rebound. All right, so the reason that you put some pressure here and why you wait until you see the signs of separation is because you don't want to have uterine prolapse or uterine avulsion. As you can see here, I think from this diagram, if you're pulling on the placenta here, the placenta is attached back here to part of the uterus. The placenta could end up like getting pulled out, right? The uterus could end up getting pulled inside out by the force on the placenta like this, right? This could go from here to here because of this force you're applying. That would be a prolapse. And also avulsion, right? A uterine avulsion. Avulsion just means tearing away as a general term. All right, so that's the third stage. That should take less than 30 minutes. And after the placenta comes out, examine the cord. You can take the umbilical cord blood as well. right? There's a lot of documentation that goes along with having a kid, as you mentioned before, and so we'll go through the note writing process a little bit. So the person will come in with their chief complaint. You know, it could be labor started, contractions. It could be they had rupture of membranes. And you're going to write this. So you're going to write your standard like 38-year-old G1, G2, P1, blah, blah, blah. And then you're going to write the dates. And you're going to say by. So by last menstrual period, consistent with first trimester ultrasound, or by ultrasound only. And then presents for rupture of membranes, whatever your chief complaint is. The patient reports, and then these are the 4 questions that you ask anytime you see a pregnant person in this setting, or just always when you see a pregnant person, no matter where you are, always think about this. So plus or minus fetal movements, question 1. Question 2, loss of fluid, have the membranes ruptured or not. Question 3, vaginal bleeding, and question 4, contractions. So just plus or minus all those things every time. Fetal movements, loss of fluids, vaginal bleeding, contractions. And then from the review of systems, you want to pull up and report out in your, so this is the subjective, right? The subjective part, changes in vision, headache, vision, right upper quadrant pain. So just denies headache, vision, right upper quadrant pain. That's it. And then just finish it up with anything that complicated the pregnancy. Note the last menstrual period, estimated date of conception, which would be 2 weeks after the last menstrual period. All right, and so continuing on, the history, this is written here because this is all just the same that you would do for anyone else. Do gynecologic, medical, surgical, allergy, family, social, right? What you do for anyone else. But the difference here you want to add is you want to add the OB history, and you want to add for each prior pregnancy, just in number 1, 2, 3, 4, write down the list, the year, dates, what happened, normal spontaneous vaginal delivery, was it a feedback, what was it, the gender, weight, and if there was any complications. So just make a list. Then go to review of systems. Again, this is just do it like you would any other patient, but things that can be easy to forget and that you don't want to have to go back and see what I forgot to ask about were vision changes. Okay, and we're thinking about eclampsia, preeclampsia, stuff like that. Shortness of breath, PE, right upper quadrant pain, biliary disease, gallbladder disease, and then headaches. All right, so make sure to ask about those type of things. Continuing on, the physical exam, vital signs, fetal heart tracing. You know that we look at baseline variability, accelerations, contractions, and then just a general. All that is just standard. The abdominal exam is a little bit different, right? You can be gravid, tenderness, fundal height, what you determine the position to be, how you did it. So ultrasound or Leopold's are the 2 ways that you determine position. And then neuro, the deep tendon reflexes and the clonus. That's important again for the preeclampsia perspective. And additional things that you don't typically do are the vaginal exam. So that's the sterile speculum exam and sterile vaginal exam. All right. Laboratory stuff, signs of infection, trichomonads, clue cells, any protein, glucose, anything on the urine dip. Then you take all the prenatal labs that you did from all that prenatal testing, which we talked about earlier, and you compile them all into one line. GBS negative. How did they do on the glucose tolerance test? 1 hour, they were 72. Hemoglobin, blood type, antibodies, everything like that. Syphilis, gonorrhea, chlamydia. So take all the prenatal testing, combine it right there. Then the level 2 ultrasound. Remember that prenatal visits at around 18 to 22 weeks. They get this ultrasound, and that is the anatomic scan. Looks for fetal anatomy, gives you an estimated weight, helps with the position, figures out where the placenta is. So you record the stuff from that level 2 ultrasound, and this should all just be taken from old notes that you find. And then the final part will be the assessment and plan. And then so just do your one-liner, 28-year-old G2P1, coming in at this many weeks by last menstrual period, presenting with labor. Okay, and then you say that the fetal well-being is reassuring, heart rate's a class 1 heart rate, you're going to admit them, NPO, fluids, any other admission orders that they need. And then 3 things that you shouldn't forget about and that you need to either do now or you'll have to do it later. If you forget, go back and ask them is what's their plan for breastfeeding, what's their plan for circumcision, and what's their plan for pain control. those are things that you need to know about right up front, and you want to get that information fairly quickly. All right, and so that was the admission note, which is quite a big ordeal, as you can sort of see. The labor progress note's a little bit of a different deal. So labor progress notes are either done Q4, every 4 hours you're going to have to go and talk to the person and look at the objective data and come up with these for people in the latent phase of labor. Remember, stage 1 latent phase takes a long time, 20 hours for primiparous woman, and then Q2 hours for the active phase. Oops. Q2 hours when someone's in active phase, so you do it more frequently. So the labor progress note, those same 4 questions that you ask to every pregnant person you ask here, so contractions, bleeding, leakage of fluid, getting at rupture of membranes, and fetal movement. So that's your subjective, nice and easy 4 things. And then so you go to the objective, do the vitals for mom, go through the fetal heart tracing as before, baseline variability. And if you're not familiar with that, that's a really good thing to, we'll make a video about that too, to learn about before you do this, because it's something you have to do every 4 or 2 hours, possibly on multiple people. Then do the contractions, so every 5 minutes. If you're using Pitocin, note that here. The sterile vaginal exam, so either you can do it yourself if you're in that sort of a role, and you do the dilation, effacement, and station. Right, so dilation, you'd say 6 centimeters. We're 50% effaced. 50% effaced, and we're at 0. Okay, or if you're not doing that, just write deferred, and then put when it was done last. So deferred, last done at 10 o'clock, or last done 10 o'clock 4 hours ago, and put whatever the numbers were then. And then you just do your A and P, so maternal well-being, how's mom doing, and then things to note there are the pain situation. Does she want the epidural, or whatever else she's going to use for pain now. Fetal well-being, what's the category of the heart tracing. Labor, has there been any progress, and then any other issues like GBS status or anything else. All right, and so now this is a really long talk, but there's a lot of kind of good information there. We're going to sort of review some of the key things. So the stages of labor, classically there's 3 stages of labor. So there's 1, 2, and 3. So 1 has a latent and an active part. Latent's up to about 4 centimeters, and then after that you have an increased rate of dilation up to about 10 centimeters. When the person's in a latent phase, you're going to be checking in on them Q4 hours and writing labor progress notes, reviewing the fetal heart tracing. They're in the active phase, when they're going up towards their 10 centimeters, checking in on them Q2 hours, writing progress notes. All right, the presentation and position. So presentation is what part of the fetus is going to be coming out and you're going to be seeing. And then position is a way to further characterize typically a vertex presentation, although it can be used with the breech. So we talked about that, for example, and it's the occiput in relation to the maternal pelvis. So occiput anterior, feel a posterior fontanelle, being anterior close to the pubic symphysis, then you know in your occiput anterior position, or occiput posterior, or occiput transverse, or whatever. You have the Bishop score, so that takes all the things that we looked at on the cervical exam, dilation, effacement, position, and others, and combines them up into a score, into a number. And you should remember that 5, if you're 5 or less, then that's not that great of a chance of an induction working. You should do cervical ripening before you induce Pitocin. And then note writing. So we just went over the notes. There's 2 general notes. One will be the admission note when someone first comes into the hospital. Went over the components of that, and then there's the progress notes that you do labor progress notes every certain amount of hours while somebody's in labor. All right, so thanks for watching. It's procedureready.com talk, so you can always go to the website for more. Consider checking out 52kids.org and making a donation. Thank you.